Hello, my name is Alex. I appreciate everyone joining. Today I'll be talking about the development of the Diabetes Registry for Northeast Community Health. Diabetes data is important to not only our organization, but for providers worldwide. The WHO states that diabetes is an important public health problem, one of 4 priority non-communicable diseases targeted for action by world leaders. Both the number of cases and the prevalence of diabetes have been steadily increasing over the past few decades. As an organization whose vision is to improve the quality of health and life of the community we serve, helping our providers to more closely monitor their diabetic patients will be an integral part of our mission over the coming years. So the intent of this project is to develop a diabetes registry, which will allow our providers to monitor the status of their diabetic patients. The database will contain a selection of patient clinical and demographic data, which can be used to help providers monitor for uncontrolled diabetes, changes in patient status, and create a little framework to address some potential causes in the future. So our original project plan stated that this database would contain data on adult patients with prediabetes, type 1 or type 2 diabetes, so patients with gestational diabetes, pediatric patients, and non-diabetic patients would not be included. The plan was to create 4 tables, one for provider info, one for patient info, one for patient demographics, and one for clinical results. We chose those tables in particular to allow providers to draw conclusions based on clinical data, but also to visualize relationships between clinical data and demographic data. For example, is glucose level directly correlated to body mass index, or is the time since diagnosis a factor in controlling blood glucose levels? And then some comparisons between clinical and demographic data would be, do patients without insurance experience higher blood glucose levels, or does a certain ethnic group experience higher blood glucose levels? Either way, the more information available to our providers and our health system, the more likely we are to be able to monitor and support our patients to reach healthy outcomes. So after the plan was developed and the need for the database was apparent, we began the first step of the database lifecycle, which is the initial study. Some of you may have been a part of this process as we identified objectives, scope, and boundaries of the project. So the first step was to analyze the company situation. We know we're going to cover 2 offices. There are both providers and admins in both of those offices. We have to define the problems and the constraints. Currently, there's no diabetes registry for direct patient caregivers, and so the providers are having a difficult time monitoring their care. We do know that there's an existing electronic health record system and existing network infrastructure. And then lastly, we needed to identify who needs to access the system and what will they use the information for. So then to define our objectives, we wanted to create a database that allows providers to more closely monitor the status of their diabetic patients and then ultimately link it to the electronic health record. And then we needed to define the scope and boundaries. So as we mentioned before, this data will only be collected for adult diabetes patients who are pre-diabetic, have type 1 or type 2 diabetes, and are also patients of one of these 2 local offices. And then this database will currently only be accessed by providers and other support staff of these 2 offices. The boundaries set out at the beginning, which many of you were probably a part of as well, is we have a $25,000 budget. We must use the existing hardware at the physical office locations and then be fully operational by June 21st, 2023. Which takes us to the next step, which is the design phase. For those of you who are unfamiliar with database design, this step is a tedious process, but it is mission critical in creating a database that functions effectively. So we'll start with the conceptual design, just where we identified who would use the information, what is the information they're looking for. excuse me, to establish business rules, define entities and attributes, define the relationships among them, and then kind of discern where the data will be coming from. And then the next step here is the logical design, which I'll show on the next slide, just a map of the conceptual model. And then the physical design, just knowing how much data we need, how much storage we need, what kind of security there will be in place, including defining users and groups and roles. We started with only 6 users, and then we can add more roles as they are required. So this is the map or the diagram of the conceptual model. As you can see, there are 5 tables here, not 4 like in the initial plan that I mentioned. These tables are going to contain information on the office, the provider, patient, visit, and results. Those table names are highlighted in blue, and then the attributes or columns for each table are listed below. I will spare you the details of going over each individual attribute, but just know that defining each and every attribute is an important step in the design process. Moving on, we enter the implementation and loading phase, which is undoubtedly the most time-consuming phase of the development. We first had to install the database management system on all the user computers. As the system admin, I created the database and assigned the role of database administrator to Dr. Kelly Smith. And so she will be able to have full access and then add and change user privileges as moving forward. Next, we have our other current users are going to be Anna from HR. She has full access to only the provider table, so as providers maybe come and go from the offices or change phone numbers or addresses, she is able to update their information. Julie from Patient Access can enter and update patient data, but cannot create or delete any tables. Dr. Raymond Young can add and delete and update tables so that he can modify the database to reflect what the providers are trying to monitor. Margaret is the administrative assistant at the office. She will have access to any views that are generated by kind of the higher level users. She often assists in generating reports and presenting information, so having access to these views is important for her job. And then lastly, Steve from IT will have the rights to do system maintenance and run regular backups and security checks. Once all of these users were created, Anna and Julie manually entered all the historic patient information. The hope for the future would be that the database would be integrated with the electronic health record system so that after each visit, the data would be automatically loaded into the database. So here are just a few examples of tables that have been populated with data. This table is for patient information. The patient names have been removed for privacy reasons. And then here's another snapshot of the results table. Both of these tables are actually much larger than what is shown here. I just wanted you to get an idea of what they might look like. And then next, we moved through testing and evaluation. The first step was to run a sample query. So as you can see here, I've created a very simple view of some information that a provider might be looking for. It's going to show the patient ID number, the patient sex, and the patient A1C level at the time of diagnosis. I ran a couple other queries and didn't come across any errors at this point. So we've moved on to the next steps, which are to test user access and then fine-tune the database. So we had each user log in and then change their password from the initial password that we created for them. And then there were no problems there. So we just quickly looked at fine-tuning, if there were any adjustments we could make to so the database would run more efficiently. Currently, this database is very small, so it doesn't really require a lot of performance tuning. If it were to grow, we may have to look at how we store the data to make it run more efficiently. So then we asked Steve to do a backup of the database and then offered end user training, so in-person education for the clinicians and support staff in both offices, which I think everyone has completed at this point. And then we will be available with live support for the first few weeks as we move into operation. So during this next phase, we definitely anticipate users to come across problems or receive some errors. We can work through these issues and make sure that everyone is able to generate the information that they're looking for. Like I said, it'll be available for several weeks to help work through any kind of operation problems. And then Steve will manage the preventative maintenance and updates, and Dr. Kelly will manage the adaptive maintenance if they need to add more tables to kind of monitor different information. But then if you get to a point where you find that the database structure is no longer meeting the needs of your organization, you can feel free to reach out. Thank you.